Started out on a one-way train. Always knew where I was gonna go next. Didn't know until I saw you.
Hi, everybody, and welcome to Pull in Perseverance. Pull in Perseverance is honored to welcome a trailblazer in the world of pharmacy, Professor Prof Schellack. While during the interview, I was reminded of a quote that embodies Professor Schellack. The quote is by Ralph Waldo Emerson, and the quote goes, "Do not go where the path may lead. Go instead where there is no path and leave a trail." Professor Schellack is a distinguished academic, thought leader, and pioneer in pharmacy education and clinical practice. With a remarkable career dedicated to advancing pharmaceutical care, she became a driving force behind evidence-based teaching, transformative leadership, and policy-shaping research. Her internationally acclaimed work in antimicrobial stewardship has not only influenced practice standards, but also sparked vital conversations around responsible use of medicines. Beyond her academic accolades, Professor Schellack is a mentor, innovator, and change maker, someone who continuously challenges the status quo to elevate the profession. Her passion for shaping the next generation of pharmacists and her unwavering commitment to patient-centered care make her a true icon in the field. Get ready for an inspiring conversation with a powerhouse who embodies excellence, leadership, and the future of pharmacy. Enjoy the episode. Hi, Nat. Hi, Prof Schellack. Welcome to Pull in Perseverance, and thank you so much for being here. I'm really, really excited to have you, especially I know that you have such a busy schedule. So thank you for making the time. So first and foremost, let me do a brief introduction of the many hats that you wear. I know that you are currently the head of department of the pharmacology department at UP. You are the SAPJ editor, plus you are currently sitting as the chair of the education committee at Pharmacy Council. And just to mention a few, because I know you have multiple hats, but I think those are the ones that stand out for me. So tell me, how did you get into academia and what made you pursue this direction?
Good morning, Prof. Veni Parayachi. So Veni, thank you for having me on the podcast today. I'm really excited to chat to you as a colleague and also as a long-term friend. I'm excited to share some of our ideas. So yes, my career actually started in nursing, and in nursing, it gave me a deep appreciation, almost for patient care. And I transitioned then into pharmacy in 2000, and it gave me a big desire, to look at medication safety. That was one of my primary goals, who takes ownership for medication safety. It's coming from a nursing background. I could see that there's a lot of danger to public health if we don't steward safety carefully. But then moving into pharmacy, I studied pharmacy at McCarter Health Sciences in collaboration with TUT. And I faced language barriers actually there. The language barriers were that I came from an Afrikaans background where I did everything in nursing in Afrikaans, and I had to do whole cultural and language transition. But that made me stronger, and it gave me a resolve. And the resolve was that we are actually, it doesn't matter what your culture, your race, wherever you come from. In pharmacy, we actually have a mutual goal, and that is to keep the public at large safe and to serve the people of South Africa. For me, that is of utmost importance.
So why did you choose academia specifically? Because you could have gone into having a background with nursing. I think normally the transition is into medicine. So I'm fascinated, why pharmacy and then academia?
So pharmacy came almost naturally to me. It is a little bit of a funny story, but I didn't like the direct death and dying aspect of nursing. So pharmacy for me was a good fit because I could utilize all of the chemistry and sort of medicine-related knowledge into public health care. So it almost came naturally to me, and it was my best subject in nursing. It was almost one of the only subjects that I really did well in. And academia, I actually wanted to be a retail pharmacist. So I worked for a while as a retail pharmacist. But academia came because of my curiosity and in understanding situations. SMU then started an internship program, and I was one of their first interns to transition into academia, and I just never left thereafter. Yes.
I'm so glad you stayed.
Thank you.
So antimicrobial stewardship is your area of expertise. Why AMS? Why antimicrobial stewardship specifically? Because there's multitudes of areas of research, especially because you mentioned medicine safety. That could have been a route, but why this?
So yes, my academic path then led into a blend of research, teaching, and advocacy. And as part of the teaching and the advocacy, when I embarked on my postgraduate studies at SMU, I worked in pediatrics. And within pediatrics, I faced in clinical pharmacy, I worked in the hospital every day. And in Dr. George Mukhari Academic Hospital, where my postgraduate studies were initially focused on, what role a pharmacist can have in pediatric care. On a day-to-day basis, I faced the devastating effect of antimicrobial resistance, especially in children, and that motivated me. I realized that resistance it's a local threat. It's almost isolated in these wards. And if someone doesn't start telling the story, we are going to have millions of deaths globally. But when I looked for the story, Veni, I couldn't find South Africa's story. And, the really someone telling the story of, yes, we are facing the HIV pandemic. That was now in 2003 when this journey started. But just riding along this pandemic is resistance with all of the antibiotics that we are using with the collateral damage. And no one at that stage felt as if there were a big priority focus on stewardship and how do we manage it and how can pharmacists really start playing a very, very active role.
So briefly, how would you define or describe antimicrobial stewardship to people that may perhaps never have heard of it?
Yes. So antimicrobial stewardship is such a large word, and I often also worry about these words that we are using, but stewardship is actually a political term, and it comes from really looking after something that is very precious. So then antimicrobial stewardship really means just to look after the antibiotics that we have and to keep this precious resource for our children and their children. And that's just a very easy description. But it doesn't always translate into a language that is spoken amongst the public, especially.
And I think healthcare professionals as well.
Yes.
That's not enough. So do you think pharmacists are aware enough about antimicrobial stewardship, or do you think, I don't want to give you too much of a loaded question, but in terms of undergraduate curriculum, do you think we're doing enough? What are your thoughts?
So maybe just to first talk about, what the role of the pharmacist and how pharmacists can play a role in stewardship. So just to give you some numbers in terms of pharmacy, I actually wrote an editorial just after the United Nations General Assembly on the 26th of September last year in 2024 on what the pharmacist and how the role of the pharmacist aligns with this call that we have from the United Nations General Assembly and where are we in South Africa. So just a short picture on that is we currently have a workforce of about 3,970 community pharmacists, and 937 of those pharmacists are in private sector and public pharmacies, but institutional pharmacies. So that's just under 1,000 pharmacists in all of our hospitals, 17,581 overall registered pharmacists. So we nearly have almost, 20,000 registered pharmacists, 22,000 pharmacist assistants, and then 7,000, almost 7,800 pharmacist assistants in training. That gives us a lot of hands. But the word stewardship is so vast that people often don't know where to begin. But there are so many roles, interventions like hand hygiene for assistance, vaccination, education, and even just speaking the local languages and ensuring that your patients know when they leave a pharmacy a little bit more than just complete the course, or making sure that they are up to date with their vaccinations. And interestingly enough, there was a local study now done in Cape Town, just published this year earlier, by Prof Schellack and team, and they actually demonstrated that within a multidisciplinary team, in these community pharmacies and community clinics, you can actually reduce antimicrobial consumption by 18%.
Wow.
Just by having pharmacists as part of the team. And even despite the multiple roles that pharmacists can play, the assistance in terms of education and speaking some of the local languages, I sometimes also feel that we are also our own worst enemy, and we inadvertently contribute to antimicrobial resistance through the business orientation that some pharmacies have. And there we see, of course, all of the over-the-counter use of antibiotics, where pharmacists sell antibiotics as a commodity. So pharmacist assistants and pharmacists can really play a major role in stewardship, but we also have to look at it from a larger perspective and address the business model in making money from antibiotics.
Yeah, absolutely. So Nancy, I mean, the argument is always that pharmacists don't have the time. So if you look at the way, and you mentioned the business model of pharmacy, and that's evolved over time because of single exit pricing and all the challenges we faced with. So how do we overcome that? Because I think a lot of, if we had a pharmacist with us right now, they would argue that they don't have the time to be able to punt or promote or educate or counsel on antibiotics. So how do we go around that?
Yes, I've seen some innovative strategies from pharmacists. So, for example, the one time I came in a pharmacy, I walked into a pharmacy, and he had a notice up that said, "Ask me why you shouldn't get an antibiotic." You just, instead of saying, "Ask me why," and then instead of promoting antibiotics, he promoted a vaccination clinic. So, there is this anatomic habits that is always advertised. So some of these structures through the Pharmacy Council and through education and policy and decision makers, to start changing the system so that patients don't stop demanding antibiotics, maybe start asking for vaccination. But there are some practical ways that doesn't only include, long hours of educational sessions, but just easy signs that we can put in our pharmacies, promoting hand hygiene, vaccination campaigns in flu and winter seasons. And some leaflets, I've heard some pharmacists also explain why there's delayed prescribing, for example, where the doctor indicated don't give the antibiotic now, but where they struggle to communicate this decision because of patient pressure. So patient pressure, I think we still have a long way to go, and that isn't necessarily something that we have an easy answer for. But there are other strategies that we can start implementing and promoting that, as you said, that can meet the immediate demand of not having enough time, but that also plays a role. And those solutions needs to be communicated more effectively.
Yeah, I agree. I always say to my students, one of the most effective ways for me, I would think, to counsel a patient is as you're capturing data, patient name, whatever, everything's available to you on a card these days. So while you're doing that, multitask. I think pharmacists are fantastic multitaskers. So to be able to convey a message across during that capturing time, you use your time adequately. So I think it's just about being innovative and creative in order to as I said to you earlier, I think longevity of our profession is at stake. So we have to show our value. And this is one of the ways that we can actually show our value. So if we don't...
Sorry, if I can just get back to that point. Also, where we've seen antibiotics being sold over the counter, I think the approach should also not be punitive. So, for example, we did a study. A study was published just now, recently this year, where we saw that almost 70% of antibiotics that's being issued over the counter were for conditions where a patient presented with a urinary tract infection, and mostly in very rural environments. So we also have to be realistic and ask ourselves, in these rural settings, some of these pharmacists are also prescribing antibiotics or giving antibiotics because really there isn't any other healthcare professional. And a patient would walk 16 kilometers and then have to walk another 8 to get a script. So there, the innovation should also come from, governing bodies like the Pharmacy Council, where we can have prescribing courses for those types of pharmacies. And just like we have dispensing licenses for doctors that are in rural settings, I really believe there is a place for having pharmacists that can prescribe HIV medication, like the pharmacist-initiated antiretroviral. We should also have pharmacist-initiated antibiotics, so that it isn't just seen as punitive, but that we are trusted collaterally with our colleagues to prescribe antibiotics when it's really needed. Then we take away this whole business model and all of these issues that we are facing, but that we are training pharmacists to know when it's really needed.
Yeah, it's responsible practice, absolutely.
Yes.
And that ties in with PCDT that's been coming up quite often, and how important it is for pharmacists to have that qualification. And as you mentioned earlier, the UK has moved towards that model of prescribing, and which is wonderful. And it speaks to accessibility and availability of medicines as well, Nats, and how primary health care is where we need to evolve towards.
Yes. Which is also the focus of the National Health Insurance, is primary healthcare. So it speaks to that. And even if you look at all of the healthcare professionals, pharmacists are still one of the most trusted healthcare professionals. And in terms of access, one of the primary reasons why I think we also have resistance in low and middle income countries is access, Benny. So oftentimes there isn't access to one specific antibiotic. And then pharmacists are mandated to substitute, or doctors prescribe a broader spectrum antibiotic. And that also causes resistance. So you are right, access is a major role player in terms of resistance.
So what could go wrong, Nats, if we don't take this seriously, antibiotics or antimicrobial stewardship? What is the worst case scenario?
Yes. Okay, so that always brings me, it almost feels like a graveyard question. And normally, what was just interesting last year, we had a fifth-year medical student. He just wrote an opinion piece. And he said one of the reasons that what he experiences in the curriculum is antibiotic stewardship are often lectures that are given after lunch. And the first slide that the lecturer put on the board is always this exact question, what the dangers and the doom and gloom of stewardship. But we have to face the numbers. And maybe just to get to that, some of the numbers of the United Nations General Assembly spoke to a high burden of deaths, and most of these are located within sub-Saharan Africa, where they can directly link antimicrobial resistance to patient deaths and mortality, which has not always been done. So 255,000 deaths were contributed just to the African region within the WHO region of Africa, and most of those were lower respiratory tract infections like pneumonia in children. So what can go wrong is currently our rates of hospital-acquired pneumonia is going up. So you can go for just a tooth extraction or a knee replacement. And I'm sure everyone listening today would have heard of a family member that has gone in for a knee replacement, and they were only discharged 6 weeks later because of a hospital-resistant infection. And that is where we are moving towards. And honestly, I don't often think we are moving fast enough in terms of creating awareness, so which makes platforms like yours extremely valuable.
Thank you, Nats. And even climate change, I think, is going to make it worse because of the way the world's evolving. Yeah, it's changed. I'm not sure if it's evolution, but it's definitely changing. So in terms of
just to speak to that point, climate change was one of the focus of the United Nations. It was their third point, antimicrobial use in agriculture, where we should set up surveillance systems, because it's not just resistance, it speaks to food security. If climate change is starting to make it difficult to feed our food-producing animals, and if we don't have antibiotics with climate change, they're also going to succumb to just common diseases. So it speaks to food security and climate change, and even gender inequality. which is interesting. We're doing some work in India with Communet, which is an organization in UCT, where we are looking at the caste system, in India, and where in some of the lower castes, females are even at a larger gender inequality in terms of being exposed to infections. And similar patterns, I'm sure, is being seen in South Africa and in Africa. So stewardship and antimicrobial resistance is also a societal challenge, and it's affecting each and every aspect of our lives.
So in terms of collaboration and teaming up with other healthcare professionals, because it's not just a pharmacist problem to solve, how are we going about that? And do you think we're making strides in that area in terms of collaboration?
I do think so. Even if I think about where I started in my career, some of our very first conversations were, how do you even approach a doctor? I don't know if you also remember many of those. How do you open up a discussion and how do you talk to doctors? But I do see that there are a lot more studies, even from South Africa, coming, that's being published, speaking about pharmacists leading these teams, or even just the multidisciplinary impact. And this multidisciplinary team is looking different to even a year ago. So it's no longer just the doctor and the pharmacist and the nurse. It also now involves an anthropologist looking at social and cultural behaviors. It involves a veterinarian moving into the One Health space, like we've just mentioned. And another aspect to that team involvement is the cultural context. And how do we convey some of these messages within the context? And that's why we have to start incorporating anthropologists and people, and even some of our community members and community leaders to help us translate. So the team is also looking different. It's a different team.
I would imagine traditional medicine as well would get involved in that as well. Yes. And faith-based organizations. Yeah, that's wonderful. And in terms of the global space, Nats, are we measuring up in terms of antimicrobial stewardship, or are we lagging behind?
Yes. So we just last week we just published a very large narrative review in 4 WHO regions, where we looked at knowledge and perceptions of antimicrobial stewardship. So this was over Asia Pacific, Africa Pacific, and we looked at and 2 other Northern Africa regions, and we looked at what are the knowledge and perceptions of patients, healthcare workers, nurses. So we stratified that, and there seems to be commonalities in all of these WHO regions in terms of the challenges that we face. Resistance, and even communication, and even just providing dissemination of information and education, and where should we start? So we are all facing the same challenges. But I think what disproportionately affects South Africa and Africa is, first of all, access. And then we also don't have a homogeneous society. We have a society that's heterogeneous. We speak different languages as well. And then, of course, African countries, an appreciable number of these papers that we evaluated dealt with how these knowledge and perceptions and the language barriers influences antibiotic prescribing at the end of the day. So we are measuring up in terms of our stewardship initiatives and in terms of all of the work that we are doing. I mean, even in that synthesis review, 42.7% of all of the work came from Africa, just less than half.
Oh, wonderful.
So that was so encouraging to see. Yeah. But only 33% of that was focused on patients.
Oh, I see.
So that gives us a good
more work.
We need more work in patients. We've done a lot of work in terms of the teams but patients, and then the patients, of course, translate to language, and how do we speak to them, and how do we involve the stakeholders. Yeah.
So speaking about patients, and one of the things that I know that you featured on recently and had a discussion on was falsified and substandard medicine, particularly in antibiotics. So that's also a space that's close to my heart. And how we Yeah, how are we getting that right in South Africa? I'm concerned because
Yeah.
because of the borders and what's happening, and we're seeing more of those medicines come across.
Yeah. So now you are concerned with right because they are showing, trends and concerns in terms of prescribing antibiotics. I'm going to talk about the borders just now, but for patients, even in this narrative review, we saw even across these four WHO regions, patients still want antibiotic for viral infections. And I think that was just one of the key findings because their knowledge in terms of what an antibiotic is and how it should work was self-limiting. And there were similar issues in terms of that knowledge gap in the dispensers. And patients had really self-limiting beliefs in terms of the effectiveness of antibiotics. And the borders, and I think you are also talking about medicines that are not registered, and being used over the counter. That is, I think, a future opportunity for us then to look at even in our dispensing courses. Like, for example, any dispensing course, I think, can include a module around antimicrobial resistance, and how do we communicate this to patients? And it speaks to health literacy that even if you have countries where there is open borders, how do you communicate to a patient in Zimbabwe that comes from Zimbabwe, a patient from Zambia? So that health literacy, dispensing courses, in prescribing courses is a future opportunity for us.
And then technology nuts to be able to identify these falsified medicines. Do you, or even antimicrobial stewardship progression in terms of testing for bacteria? Do you think we are geared up in South Africa to manage that?
Yes, I think AI, is providing large platforms for us. And instead of being scared of it, I think it's a great way to use it almost to translate some of the messages that we want to convey to our patients. In South Africa, there is a lot of high technology apps enabled that enables education, for example, and even speaking to early diagnosis, in key diagnostic features to diagnose between a viral infection and a bacterial infection. Some of those apps
Yes.
are hitting the market. And there's a lot of work being done in stewardship and diagnostic apps, and then especially in mHealth, and in looking at surveillance apps. And how do we, there's a lot of work in South Africa now around next generation sequencing and combining that with AI. So I'm especially excited around, just finding some of these resistant genes and then putting them in AI. And then we know there's a Listeria monocytogenes outbreak, for example, in Baragwanath Hospital. But there was also a foot and mouth-borne disease in some of the farms outside. So I am seeing some of that geo-mapping happen. I'm seeing some of the diagnostic stewardship apps coming out. I'm seeing some education enablers. So South Africa is doing very well. And South Africa, interestingly enough, has some of the most advanced technological guidelines for mHealth and legislation that enables this sort of work.
Yeah, that's wonderful. It makes me proud.
Yes.
We could talk about antimicrobial stewardship much more, but I want to move on to your other role as the chair for the education committee at Pharmacy Council. So tell us, how did you get there in the first place? And I know this is your second term. Clearly you enjoy it quite a bit to take on a second term. And also, what does your job entail as the chair?
So yes, this is my second term, and I'm thanking all of the pharmacists that voted in the profession. But each term is 5 years, so this is now I think it's my 7th year in the Pharmacy Council. So I got to that role by pharmacists voting for other pharmacists, elected member of the Pharmacy Council. But my main drive then was also for clinical pharmacy and advocating for clinical pharmacy, being incorporated as a specialization in the Pharmacy Council. And we did a study in 2018 to look at education, pharmacy education across the 9 pharmacy schools, and what education is being provided. Are there statistically significant gaps in stewardship in pharmacy education? And that study then found that, yes, we don't provide the same level of education across the pharmacy schools. Currently now, my role is the chair of the education committee. So we look at all of these short courses and evaluate, accreditation visits to the pharmacy school. And the Pharmacy Council has been very progressive in terms of including stewardship factors in the undergrad curriculum, from the first year to the second year, to the fourth year, apologies, with progression in terms of the knowledge applied. So first year, just introducing stewardship and resistance, to moving into the fourth year in how do we implement it, how can we manage it, and how can we lead some of these stewardship initiatives. I do think there's a lot of work still that needs to be done in terms of prescribing from the Pharmacy Council. As you know, the Pharmacy Council is waiting for the Constitutional Court's finding if pharmacists can prescribe antiretrovirals, first-line antiretrovirals. And I think that is important because HIV ties into antiretrovirals, and that will allow, I think, a lot of room for future roles of pharmacists in this space.
Yeah, absolutely. So other than managing and looking at how clinical pharmacy could be incorporated more effectively within the undergraduate program, what is your other roles? And one of the first things that come to mind is the responsible pharmacist course that everybody is up in arms about.
Yes.
So how do you feel about that? And I know you limit it based on your role and what you can say. But I mean, where are we at with that course, and how do you see it being brought out into the profession?
Are you referring more to the responsible pharmacist role,
Yes.
or just in general?
In the course, and in general, I would imagine.
Oh, the PMARD court case.
No, the responsible pharmacist
course. Okay, so for many of these short courses, it was born out of discussions that came either from disciplinary processes or frequently asked questions. So the responsible pharmacist course also came from many of the complaints that we've received, either from inspectors or from the public, where we realized maybe we are not capacitating pharmacists enough to understand what their role is in terms of managing a pharmacy and being responsible for medicines. So I understand the up in arms, because many pharmacists feel that they've studied now for 4 years and now they must do an additional course, just to perform the work that they're already doing. But the responsible pharmacist course and many of these short courses have been brought out to enable pharmacists to do their work better. And down the line, to manage and provide public safety, which brings me back to my very first point, and making sure that everyone knows what they need to know. And just as a last point there, and maybe more on a personal note, I've also seen that this short course can protect many pharmacists, because there are many giant retail groups that are not necessarily owned by pharmacists. And some of our very young pharmacists are being almost pressurized by these groups, and they don't always understand what they can and what they cannot do. Many times they're saying they're doing a renovation overnight. And I do believe that some of the aspects and many of the aspects in the course will help these pharmacists also understand what are the implications of this business type model, and help them defend their position and protect themselves against many of the pressures that they are facing to meet at the end of the month the overhead target. So it's also a preventative measure to capacitate them for their course, because we are seeing a shift from just a pharmacist-owned pharmacy, where being a responsible pharmacist comes easier because you are the owner. So you can close the pharmacy now. Whereas if you work for someone else, it's difficult to convey what your roles and responsibilities are.
Absolutely. And I think it extends to big pharma as well, pharmaceutical companies and RPs there.
Exactly.
So that's concerning. In terms of specialization and staying on education, we know that there's been a board notice put out for comment on specialization in particular areas like
Yes.
clinical pharmacy and industrial pharmacy. And what are the other areas do you think we can look forward to in terms of specialization?
Public health management, and in terms of your specialization for pharmacists to also become public health specialists. And I would love to see a specialization in infectious diseases, but I have seen some traction in the veterinarian space, and there is a course being developed, a master's degree for pharmacists to become specialists in veterinarian medicine, which would now nicely speak into One Health. And there are many pharmacists out there that are working as a veterinarian pharmacy. So the Pharmacy Council, I believe, is also ideally positioned to provide a specialization in that course. And I think it would be good later on to also think about a specialization in education for pharmacists, which is something that the nursing profession has. Before you can teach at a university, you first need to go and do a year-long diploma in education.
That would be wonderful. So
great.
in terms of global trends, Nats, do you think that be in line with those kind of trends in terms of specialization? Because I think there's always a debate around us graduating as generalists and not specialists.
Yeah.
Because a lot of countries globally, you would see that there's a track towards, like in Canada, where you would specialize and you do a PharmD and you have residency, etc. We don't have that in South Africa. So do you think that's a positive step?
Yes, initially we had a little bit of hesitation because our workforce, we had to almost be a jack of all trades. You had to, look at your stock, you had to be in manufacturing, etc. But now I think there's a double bonus for us at the moment, if you want to look at it like that, in terms of having pharmacy technicians. And the pharmacy technicians are now doing a 3-year course. And I did an internship in London, and that really gave me a vision of how clinical pharmacy can work in South Africa. And we are moving towards that, where the pharmacy technician takes ownership for stock and manages all of the stock-related issue. And the clinical pharmacist was free to go to the wards with a pharmacist technician, doing a ward round. And while you are in the knowledge field, which is really the field where we are globally in now, it's a knowledge generating money field. I can't remember the word, I think you have it maybe, but there we can apply this knowledge, have a pharmacist technician perform their role, and that could then lead. I saw one of your listeners also ask about super specialization. And eventually, I could see that I would call it advanced level practice. I'm always worried about super specialization, but an advanced level of practice where you work in pediatrics, but you maybe work in pediatric cardiology or in pediatric nutrition, pediatric infectious diseases. And our workforce is increasing. So I think there's a lot of room to be excited for, but there's a lot of ownership in terms of managing the transition carefully and navigating it with, having patients' health at the first and foremost.
Absolutely. Patient care as a major outcome. Yeah.
Yes.
So in terms of postgraduate as an academic and staying on education, do you think there's an upward trend towards more and more pharmacists getting postgraduate degrees? And would you recommend young pharmacists to pursue postgraduate degrees? What is your opinion on that?
I think now that specialization is going to be recognized, there's going to be more pharmacy schools that are going to offer an opportunity for postgraduate specialization and training of specialization. Previously, there was a hesitancy by many of the pharmacy schools, which one can understand, because there almost didn't seem to be a market where you would give these specialist pharmacists to. So, but even in those times, as you know, I've been a very passionate advocate for clinical pharmacy, because clinical pharmacy doesn't just have to be practiced in a hospital. Pharmaceutical care is a term that comes with us from first. You can be a normal pharmacist now working in Dischem and in clinics, and you can practice clinical pharmacy. But you can become a clinical pharmacist specialist by pursuing a postgraduate degree, but not always just for the specialization, but also to empower yourself and to get more knowledge and to answer more questions that you may have. And through that process, you will define your own role and start a whole new traction for other young pharmacists to follow. So it's something for you, but it's also to pay it forward. When you are a little older as a young pharmacist, you can create an opportunity for other pharmacists to follow in your footsteps. So I would always say yes.
Yeah, I think these specializations will really transform the profession. And it will
Yes.
give more purpose to pharmacists, because I think sometimes we get lost in which direction to pursue. But once you find your passion and
Yes.
you run with it, I think you just grow
And there should be
immensely.
upskilling of these healthcare professionals with the current trends.
Yes.
Pharmacogenomics, precision medicine, early recognition. So our specialization should always be in line with what is happening. And now I think more pharmacy schools would start offering it, because there was also a limitation in terms of the number of schools that offered these types of degrees.
Yeah, even medicine therapy management, I think, is almost forgotten sometimes. And we play such an essential role in that, especially with the drive towards cost-effective medicine.
Yeah.
I think we need to pursue that. So in terms of challenges that are faced within the profession, in terms of education and the curriculum as a whole, is there anything that you're concerned about and you think we need to improve, or in general, now that you've had such a wealth of experience within the education committee?
Vini, I'm actually, the Pharmacy Council is very progressive. They're busy with a accreditation outline to navigate and to assist schools to better understand what is expected in terms of accreditation. There's many of the healthcare professionals and even courses like medicine and nursing, you have to almost navigate your way around the SAQA document and some very minimal information. So the Pharmacy Council has been very progressive in terms of starting investigating what is the accreditation outline, and at what level should this be offered, because many of the disciplines can be offered in different levels at in a different way, and then also to allocate credits towards those outlines and outcomes. So at the moment, I'm more excited than worried in terms of the BPharm curriculum. I do think it's not static, though. One must always remember that a curriculum is a living document and a living and breathing organism, because as we move forward and we face challenges, our curriculum should be resilient in responding to these challenges. Yes, and maybe some of these courses, like the responsible pharmacist course, some of the vaccination courses, I would see could be offered as mini credits in the course, because you could get very bright students. Like we see, a lot of students that are so bright, they almost become bored. And they could then start doing some of these other courses and get them as a CPD or mini courses or mini credits to have some innovation in our curriculum.
Oh, that's wonderful. So incorporated within the current curriculum.
Yes. So that
they
isn't there
graduated
yet. But I can see that being something that we can incorporate moving forward, instead of having an over-congested curriculum.
Yes, and that's always my concern, because we keep adding.
Yes, we do.
Constantly add,
Yes.
In terms of globally, do you think we meet the standards as a pharmacy curriculum, meeting up with the rest of the world?
It's a difficult question, as the pharmacy curriculum looks so different. In America, they graduate with a PharmD, and so I think for our context and for South Africa and Africa, I do think we definitely meet the standards, but my concern is towards every institution has what I call a nuts and bolts. It's almost as if Veni starts in that institution and Veni's primary passion is malaria, and all of a sudden you'll see a lot of malaria lecture, and then you'll see a new lecturer coming in and it's AMR, and then that it's just all bolted on to the curriculum. So my biggest concern is often at an institutional level, to do regular review of your curriculum and to see, do we really need all of that work? Can we get away with less work? Can we do it differently? And then there's also some institutional, there's still a legacy, Benny, that we can't completely move away from in terms of access. So some institutions also have better access to facilities in training pharmacy students than other access. So just in terms of even not just the curriculum, but in terms of facilities, we also need to do due diligence in making sure that the same type of facility access is available for all pharmacy students across South Africa.
Yeah, so it makes it generic across the board, and we have the same
Exactly.
quality of
Yes.
students that are coming out. Yeah,
Yeah.
absolutely.
Yes.
So in terms of education and pharmacy students, what advice would you give to them? Not just necessarily into any profession, but even just academia as well. If they want to get into a space and they aspire to be another Prof Schellack, what advice would you give them?
Or another Prof Pariachi, but for me it would always be seek mentorship.
Yeah.
You know, so be proactive in your approach to seek mentorship. And, you know, once you've sought mentorship, embrace that change. Because with the mentorship, there would be change. So I see many students seeking mentorship, but if it doesn't necessarily fit within their space, it's difficult for them to manage. So when you seek mentorship, be proactive in seeking change as well. And then another important factor for me, what we've recently started we've started an antimicrobial stewardship initiative where we just have a lot of co-workers and people that just want to work with us is part of this collective. But the students, we are really advocating that students' voice should be heard. Because if you look at any country and you look at some of the biggest change that's happened, you know, even democracies and major country changes, it came from the youth. You know, so your voice and actions can really drive change and can incite meaningful change, especially in stewardship. So I'm always advocating for students to put out their TikTok videos and their YouTube videos to start, you know, just broadcasting the message within pharmacy and medication safety and whichever aspect you are working, but do it in a meaningful way.
Absolutely, because they have a platform we never had as students.
Exactly.
Social media, yeah, to be able to
Yes.
get the message across would be wonderful. Thank you, Nas.
Yes.
That's wonderful advice. Thank you. So the
Thank
last
you.
component is your really special role as the editor of the South African Pharmacy Journal, which I'm so excited for. And I'm not sure if the audience knows, but you know the journal is on its way to being accredited. So from your experience working with the SAPJ, I'm not sure how many years, or should I say decades, do you think we have enough readership for that particular journal?
So, yes, thank you, Vinny. And, you know, you were also a section editor to the journal. But I've actually now only been with the South African Pharmacy Journal since 2023. So it's almost 18 months now. So it's a completely new role for me. And it was exciting in the sense that in South Africa, we don't have an accredited journal. And I know for many people that are practicing, it doesn't necessarily mean anything. What does that accreditation mean anyway? But it means a lot because in terms of accreditation, it means that we can publish research that can drive change. And then those scholars that publish in the journal can then contribute to citations for their universities and evidence-based practice. So we are very excited to say that the South African Pharmacy Journal is now, I think for the last 6 or 7 months, I would say early 2024, it's been indexed by Sabinet, the Web of Science and Scopus. So that really ensures that it's internationally visible and credible. So that is another platform for pharmacists to have a voice and to start publishing the local work that they are doing to an international audience. So what that means is if it's already listed on Scopus, it does not necessarily always require inclusion, but we have applied for inclusion on the Department of Higher Education's list. And it's an open access. It will have a flat fee page for articles that it can be open access. And we are really looking forward to that process in driving change and having a voice for pharmacists and other healthcare workers that wants to bring research to our attention.
Absolutely. I'm really excited about it. It's wonderful
Yes.
news. So in terms of research, do you think, okay, my question would be, can anybody publish within your journal, or do you have to be tied to an academic institution?
Now anyone can publish in the journal. And what's nice about that is because it's also a practice-based journal. So it's for the
Yeah.
Pharmaceutical Society, it's linked to the Pharmaceutical Society of South Africa. It's their journal. So the practicing pharmacists can still access locally peer-reviewed papers or just evidence-based reviews or receive news from the organization. But if they've done a great study and they meet all of the author guidelines and the criteria for publication, they can publish the work that they are doing in their community pharmacy, even if they've done it on a coding. There's lots of coding initiatives that I know that are doing, pediatric initiatives. Lots of the interns can publish their intern projects in the South African Pharmaceutical Journal. So it's open to all national, and we are onboarding some of our international editors as well from our African countries, so that we can have a larger representation across South Africa and Africa, and then globally.
Thank you. So I really think as South African pharmacists, we need to do more research and publish more and get the word across, because I think we do a lot of work that goes unnoticed. So it's a great
Yes.
opportunity to be able to use this platform to get the word out.
And Veni,
So
that
thank you.
research, thank you. That research, it would be great to receive some practice-based research,
Yes.
case studies,
Yes.
and everyday application types of studies.
Yes.
And I also often encourage researchers and practitioners to say that even negative results are results.
Yes, exactly.
Yes.
Absolutely. Thank you, Nats. That's wonderful. So there's just so much we could talk about, but we have to conclude.
Yes.
Is there any parting comments from your side that you want to share with us? Some wisdom, Nats.
From my side, I want to thank you just by saying thank you for having me, on this podcast. And I've always believed that together, we are so much stronger. There's always that analogy of a rope. And if you just have one string, then it breaks easier. But if you have a few strings, and the more strings you have, it becomes very difficult to break. And now, I've moved out of a pharmacy school into a pharmacology school. So it was a very steep learning curve for me. But I've realized there's a lot of merit in working together. And from a perspective that's now a little different, I've seen how strong the pharmacy profession is. And I'm very proud to serve in the South African Pharmacy Council because it's a very progressive council. And what makes pharmacists great is they work together. They have the ability to work together, which I have seen in other professions, but more so in pharmacy. So I just want to say, keep it up, because together we can really make a difference. And for me, always, especially in stewardship and in shaping the future of pharmacy together.
Thank you, Nats.
Thanks,
It's a
Benny.
beautiful sentiments. Thank you so much. And thanks for being here. Really excited. Oh, some parting, one more question before you go. What would be the best book that you would recommend to people who are listening in that has shaped you, not just professionally, but also personally?
Sure. I would want to send you a whole
list.
But at the moment for me, what I love engaging in is The Speed of Trust. I've just read that. And then another book that I've read is Extreme Ownership, but I've read that also earlier, where you really take responsibility for each and every little thing that you do in every aspect of your life. And then I'm, in terms of other books, I'm a very big classic fan. And then there's lots of books that one can mention there. But those two books at the moment has really shaped my way of thinking currently.
Thank you. Thank you for sharing that. Have a great afternoon.
Thank you,
Nat. Professor Natalie Schellack truly embodies impact, and this was evident in every part of our conversation, from antimicrobial stewardship research to education and leadership. She is driven by change and is a gracious, progressive leader in pharmacy. Her story is genuinely inspiring, a powerful reminder of the difference one dedicated individual can make to an entire profession. Thank you for listening. I hope you enjoyed this episode. If you did, please like and subscribe. Stay motivated and keep thriving, learning, and leading. Thank you.